Welcome to our lecture on obsessive-compulsive and related disorders. This is a new group of disorders that emerged with the DSM-5. Prior to that, these disorders were in the DSM, but they were in other categories of disorders. With the DSM-5, they were reclassified because of the evidence that they are indeed related conditions. In everyday language, we'll often hear people say somebody might be obsessive-compulsive. Today we'll hear a little bit more about what that actually means. With obsessive-compulsive disorder, individuals have obsessions or compulsions or both. Obsessions are thoughts or urges or images people get in their head. They are unwanted, they're intrusive, and they cause considerable anxiety and distress. And it's important to note these are not worries about real-life problems that individuals have. These can be disturbing graphic images. They can be a thought that something bad is going to happen. They could be an urge to do something like hit something. Individuals will attempt to ignore, suppress, or do things to neutralize these thoughts. And they will often then engage in another action or do something else to try to get rid of their obsessive thought. This is a list of the most common types of obsessions. Concerns around contamination, both contaminating others or being contaminated by others. Aggressive impulses to hurt something or break something. Images with a sexual content. Somatic concerns, meaning concerns about the body, or a need for symmetry. And typically when individuals have one obsession, you'll find that they have multiple obsessions. Compulsions come in a number of different forms. One way is through repetitive behaviors. These are things people do, such as hand washing or ordering things, or mental acts, praying, counting up to a certain number. Individuals either do these repetitive behaviors or mental acts because they are driven to do them because of the obsession or because of rules that they feel must be rigidly applied. Compulsions are aimed at preventing or reducing the distress that the individual is feeling, or preventing some dreaded event that they believe will happen if they don't engage in the compulsions. It's important to note that behaviors or the compulsions are not connected in a realistic way, or they're excessive. But for some reason, the individual has made a link between the obsessive thoughts that they have and engaging in this mental act or behavior, and they believe it helps them to stay safe, or at the very least, it relieves the anxiety that the obsessions are having, but it only relieves it for a little while. There are a variety of different types of compulsions, but some of the very common ones are having to check in on something. This might be going back and checking that they locked the door, checking that they turned off the oven, checking that they turned off the iron. And even though they know that they did it and they can remember they did it, having to go back and check again, check again, check again. It can also be through having things ordered and arranged in a particular order, or even the act of ordering and arranging, and certainly washing and having to clean things. The obsessions or the compulsions for obsessive-compulsive disorder cause clinically significant distress or impairment and are time-consuming. So they're taking more than an hour a day to engage in their compulsion or their obsessive thoughts. You'll notice throughout the semester that we will often have additional information that can help us differentiate the best diagnosis and whether or not a particular symptom should count for one diagnosis or for a different diagnosis. And as a general rule, we don't double count a particular symptom. As an example, if someone has an obsession with food, but they're also diagnosed with anorexia nervosa, that preoccupation with food is better contained under the anorexia diagnosis, and we would not then give them an additional diagnosis of obsessive-compulsive disorder. So the rule is the content of the obsessions are not limited to the content of another disorder. However, it is very possible that somebody could have obsessions with food and qualify with anorexia nervosa. And in addition to that, they have obsessive thoughts about contamination, and they engage in compulsions to reduce the anxiety that the obsessions cause. And that very well could then qualify for a diagnosis of obsessive-compulsive disorder, in addition to their existing anorexia nervosa disorder. Another thing you'll notice across the semester is that we have rule-out conditions, where we say the condition is not due to a general medical condition, and it's not due to substance use. And this basically says we don't throw in an additional diagnosis if we already know those symptoms fall under a medical condition, or if we know that they only showed up because of a substance they used. Last, for obsessive-compulsive disorder, we would add a specifier, and a specifier is an extra concrete piece of information that clarifies something important about a diagnosis. And typically, this is connected to research that gives us additional information about the progress or what we might expect down the road, or what might be useful for therapy and treatment. In this case, for obsessive-compulsive disorder, we add a specifier if it is tic-related. So anyone who has had a current or past history of tic disorder would get that additional specifier at the end of the obsessive-compulsive disorder, tic-related. Interestingly enough, about 30% of OCD cases has a current or past history of tic disorder. Both the world and the US prevalence rates for obsessive-compulsive disorder are the same. The 12-month prevalence is roughly 1%, 1.2%, and the lifetime rate is 2 to 3%. And generally, a large proportion, 25%, will start to have symptoms by the age 14, and it is very, very rare for someone to develop symptoms without having had any in the past after age 35. We know that women have higher rates than do men, but men who have obsessive-compulsive disorder are often worse. And we see this showing up in a variety of different ways. One, men typically have an earlier onset, where nearly 25 of them typically began before age 10. And as a general rule, when a disorder shows up earlier than normal or earlier than the average, that's often going to be a worse case than someone who started at the typical developmental time. Women's symptoms tend to focus more on cleaning behaviors and checking for safety, whereas men's symptoms are often related to having forbidden thoughts, often sexual or aggressive impulses, and a desire for symmetry. And men are also more likely to have a comorbid tic disorder. So men are more likely to be part of that 30% that has OCD and a tic disorder. It's also important to note that tic disorder is associated with an earlier onset of OCD and worse severity. So all of these things end up tying together and comparing with one another. One of the things that happens whenever I teach about OCD and I talk about some of the behaviors, many of the students in the class will kind of get a worried look on their face because they engage in some of these behaviors. That's actually not at all uncommon. Roughly 10 to 15% of all college students will engage in checking behavior, having to go back and make sure that they check their door. And even though they know they checked it, going back and check one more time. And even though they know they just checked one more time, going back and checking once again. The number one thing to do if you notice yourself engaging in these behaviors is stop 100%. You lock the door. Once you know that you've done it, do not allow yourself to go back and do more checking. After your body acclimates to the initial anxiety, it begins to go away, and that urge to keep checking will also begin to go away. Although a variety of people will have some obsessive-compulsive symptoms at some point in time in their life, the course can actually be quite difficult for those who have a full-blown diagnosis of obsessive-compulsive disorder. We know that those who have the onset in childhood are far more likely to have persistent symptoms throughout their lifetime, and that they're going to be unlikely to get better without significant intervention in therapy and treatment. Typically, when individuals are under stress, their symptoms will increase. And this might be somebody who's actively symptomatic, and during stress, their symptoms become worse. And it could also be someone who is not actively symptomatic, but under stress, some of those symptoms begin to show up again. And as you might imagine, the effects of OCD can be really debilitating on their social relationships, whether it be romantic relationships, friendships, and other family relationships, because the rigidity and the anxiety around following these various rules, maintaining a space in a particular way, or having to engage in these time-consuming rituals can be difficult for others to cope with, often be difficult for people to follow in a way that is sufficient for the individual to feel less anxiety and comfortable, and very stressful on that partner. And the ideal treatment for obsessive-compulsive disorder is something called exposure and response prevention. Here we're exposing patients to the object or the experience or the situation that they are terrified of, and we have them stay in that position without engaging in the compulsions that help alleviate the stress that they're experiencing because of the obsessions. So again, people have these obsessive thoughts that something bad is going to happen, or I did something terrible, or I didn't check and I didn't actually lock the door, and they feel more and more building anxiety. And then when they engage in a compulsion, it helps that anxiety go away. The problem is, by engaging in the compulsion to relieve the anxiety, they're actually making the link between these things stronger. And so what they have to do instead is completely break that link by being exposed to what's making them anxious, and then not engaging in the response that helps them feel better. Now, of course, we do this in a kind way. We teach people corrective thinking. We teach people things to do to help control their body. We prepare them for the process, and we let them know that if they're willing to do this, it will very quickly get better, and they will stop having so many obsessive thoughts, and they will stop feeling so anxious. So they're well prepared for the process. But we do have to break that link between whatever it is that's making them anxious and then this maladaptive response that makes them feel better, but only for a little while. Exposure and response prevention is actually very, very effective. Around 60 to 70% of cases who go through exposure and response prevention do indeed get much better and may even no longer qualify for the diagnosis. Our next disorder in this category is hoarding disorder. And this is one of the things that got repositioned with the DSM-5, because hoarding used to be seen as a subtype under compulsion, so a type of compulsion. And now it's being recognized as a disorder in and of itself. Here, individuals have consistent difficulty with parting with their possessions or discarding things that are of no value. As a result, they end up accumulating amounts of stuff, of belongings that clutter their space, that congest their living areas, and make it so they can't use the spaces in the ways that are intended. When you talk with these individuals, what you quickly see is they have a difficult time understanding where that cutoff is between what's needed to be saved and what they need to get rid of, and a distortion in the amount of distress that they have at the thought of giving something away or discarding with something. This can be a full range from relatively mild cases to cases where individuals physically cannot use their spaces, or their spaces are dangerous and maybe even risk being condemned because of the amount of clutter and the items and belongings that are in there, and sometimes even can result in there being health hazards like mold, animals, feces that are intermingled into their belongings. But I want to be careful not to create a stereotype of what hoarding looks like. And if you've ever seen the show Hoarders, you'll know what that stereotype is, that people hoard to the point of being often very disturbing in the content and the condition of their home. And there's actually a full range. Some people may hoard and be incredibly neat and organized, although often the sheer amount of belongings and items can overwhelm any system they might have. And some people will hoard, and the nature of their hoarding actually does become a health hazard because of the conditions they live in. But we should not assume that that's everyone, and we should not make assumptions about their social class or their backgrounds, because hoarding is actually much more common than most people realize. In providing a diagnosis of hoarding disorder, we also have the opportunity to add specifiers. And one of the specifiers is with excessive acquisition. So with excessive acquisition, here these individuals are acquiring new things. This might be excessively buying things, stealing items, taking free items and keeping free items. Here, the fact that they don't have space or they don't need those items is not important. They continue to keep acquiring things even though they know that they don't need it and they don't have space for it. And we see this in anywhere from 80 to 90% of cases. The nature of hoarding disorder often means that people can keep it a secret and keep it hidden from others for a very, very long time. And this hinders our ability to have an exact idea of how commonplace this is. But I can say, even though I teach this class of over 250 students, I've never had a class where if I ask about somebody who meets this criteria, and at least a third of the class says they know someone who at least seems like they might fit the criteria for hoarding disorder. So the prevalence is not known. When they've done community surveys, they find that it might be as high as 60%. I'm sorry, not 60, 6%. Epidemiological studies find that these rates are higher among men, but clinical studies show that the rates might be higher in women. And this could range from a variety of things, from being more severe, and perhaps that being why they're in a clinical study. It may also be that women are more likely to reach out for help, and so they're already included in those clinical samples. But it's always interesting when you see a difference in the community rates and the clinical rates. We also know that hoarding disorder is more common as adults get older. So 3 times as high in those 55 and up compared to younger adults in the 34 to 44 range. And the course we often will see is that it begins or first kind of peaks at around 11 to 15 years. And then by the mid-20s, it starts to interfere with their ability to function. And then individuals have clinically significant impairment and dysfunction by their mid-30s. And unfortunately, the course for hoarding disorder tends to be chronic and to continue getting worse and worse as they age. Equally challenging is there are very few ways for individuals with hoarding disorder to get help. And unlike the TV show, going in and taking people's stuff and throwing them out when they're not there, or high pressure situations for them to make choices about getting rid of their stuff on the spot, can actually make their hoarding disorder much worse rather than making it better. It's also difficult because it's an intervention that often would require that a clinician go to their home on multiple occasions and often for a long period of time. And that's simply not something that insurance companies are willing to pay for. So there's many, many reasons why it can be difficult for individuals with hoarding disorder to get the clinical help that they need. But there are efforts to hopefully improve services for this population in the near future. Body dysmorphic disorder is the final disorder we're going to talk about in this category. And this is another disorder that got shuffled around because it used to be in the somatoform disorders, those disorders that have to do with the body. And even when it was back there, I would often talk about the fact that the pattern of this disorder really is very similar to the anxiety disorders, similar to the obsessive-compulsive disorders, and this was later validated with the DSM-5 shifting this disorder into that new category. The essential feature for body dysmorphic disorder is a preoccupation with something that they believe is a horrible physical defect or a flaw that is disfiguring, impairing, something like believing that their nose is completely deformed, maybe their hair is a horrendous color, their chin is too big, or their teeth are too yellow, but they feel like there's a defect about them that is so ugly and so hideous that they cannot risk it being seen by other people. As a result, you see a similar set of kind of thinking and responding. So having these obsessive thoughts about how ugly that perceived defect is, and then engaging in a variety of mental acts or behaviors to help reduce the anxiety they have about this potential defect. This might be checking in a mirror to see if perhaps it's looking really bad right now, or asking other people questions to seek reassurance. They might engage in things in their head, like comparing the appearance of their body part to others, and does it look like it's all that different? What's important here is they are having these obsessive thoughts throughout the day and engaging in these checking or reassurance seeking or these things that help them reduce that anxiety all throughout the day. Sounds very, very similar to obsessive compulsive disorder more generally. It just manifests as a particular perception of a defect within their body. Once again, we would verify that the symptoms we're seeing are not better accounted for by another disorder. For example, the preoccupation with being fat that we see in anorexia nervosa would be better characterized under that disorder and not also giving this as an additional disorder. But if in addition to anorexia nervosa, they also had this belief about a defect perhaps with their face, and then they engaged in several behaviors to correct for that, we could consider both diagnoses. And another set of some of the common behaviors that we see with this disorder, frequently glancing at a reflective surface like a mirror or windows, picking at their skin, avoiding reflective surfaces altogether, repeatedly measuring or touching the part that they think is defective, repeatedly asking for questions that would give them reassurance about the perceived defect, having elaborate grooming rituals to cover or hide the perceived defect, or touching it repeatedly, touching it, patting it, hitting it repeatedly, trying to camouflage what they see as a perceived defect with their hand or hat or makeup or even some kind of scarf, avoiding social situations where that defect might be seen by others, feeling incredibly anxious when around others and wondering if people are seeing it, and even frequent attempts to have plastic surgery in order to protect others from seeing it. And finally, one that can easily be misconstrued is refusing to leave the house or needing to leave the house with something that completely hides their appearance. You can imagine if you don't ask enough questions, you could misdiagnose somebody with agoraphobia because they were refusing to leave the house when it's really simply a refusing to leave the house because of this preoccupation with an imagined defect. one of the reasons why we don't only need to assess the symptoms that we see, we need to ask the follow-up questions to understand why those symptoms are showing up, or what is the purpose or motivation of those symptoms. The prevalence rates in the United States for body dysmorphic disorder hover just around 2.5%, with women having slightly higher rates than men. Those who have an early onset in childhood are associated with a higher number of suicide attempts and frequently have more comorbid disorders and more severe conditions than those who start later in life. Women's presentation of body dysmorphic disorder are often going to be comorbid with the presentations for eating disorders, which can make things a little bit complicated. Men are more likely to have a preoccupation with their genitalia or around body dysmorphia, the idea that they don't have enough or they have insufficient muscle. And it's important to note that this is not a culture-bound disorder, although the way it manifests can be influenced by culture, meaning the areas that are of concern are related to cultural norms. It might be whether or not my hair is long enough as a woman, or if my hair is thick and full enough as a woman. It could be about my hip to waist ratio as a woman. And in another society where that hip to waist ratio is not as much of a concern, maybe that would not be the symptom that is a focus, but maybe it would be something with my facial structure. So again, we see this around the world, so it is not culture bound, but the way that it manifests is influenced by cultural norms around beauty and expectations for appearance. And once again, the effective treatments for body dysmorphic disorder are very similar to what we've seen with the other obsessive compulsive and related disorders. Exposure and response prevention, drug therapy, and in particular the SSRIs.